All right, continuing our journey on how we're implementing the treatment recommendation within Missouri, we now have Dr. Sarah Hampl, who's a pediatrician and a professor at Children's Mercy with UMKC, where she got her medical degree. She has been a tireless advocate for weight management services in Kansas City, as well as the bi-state area, as well as nationally. So we're very honored to have Sarah as part of our team, and she's going to highlight how we're developing supports for the workforce.
I really am grateful for the opportunity to speak about this, and as Denise and Summer and Deb have mentioned, it's been really fun and a great learning experience to be able to work with partners across the state and see this process be able to happen and start being implemented. It's been very rewarding. In terms of how I got interested in childhood obesity, it was really through my own primary care practice at Children's Mercy in the mid-90s when I started seeing kids really suffering with obesity and its complications, both medically and also emotionally, and that's just my interest in the area just kind of grew from that. So today I'm going to talk about the preparing the workforce, and we want the treatment benefit, the policy change to be successful, and a big part of that is preparing the workforce, preparing the healthcare professionals who are going to be treating these kids, and that's just one element of the whole socio-ecological model, but it is one that we think is important to have happen before the benefit is released, so that's what I'm going to be speaking about this morning. So I wanted to review a couple just challenges that we have in our state, as well as some strengths, and these are some of the things that we started out with. We are in a largely rural state with limited access to evidence-based treatment. We also know that in looking at what other states have done on a state level, there's not that many models out there to look at in terms of how to replicate good work that others have done. We really did not, starting out, have an existing partnership for childhood obesity treatment between our state professional organizations, and that's been one of the benefits of this process is we're starting to see that collaboration start to happen. We have an underdiagnosis of obesity. We've actually started looking at some baseline data for this work in conjunction with the MU Office of Social and Economic Data Analysis, or OCEDA, and they looked at around 519,000 kids in Missouri Medicaid in the year 2016, and the rates of obesity diagnosis were 2.6%, and we know that from the national data that it should be much higher than that. So we're facing underdiagnosis, which is not unique to Missouri, but that's one of the issues. And then, as mentioned before, there's not national certification for family-based behavioral treatment. On the flip side, though, we have strong professional organizations interested in doing more for childhood obesity that have really come together and continue to work together. We have MOCAN, the Missouri Council on Activity and Nutrition, that you'll hear about more. That's an established coalition for a number of years that's currently administered through our MU extension. We have committed partners in multiple sectors. We've got expertise with Dr. Wolfley and her colleagues at WashU in family-based behavioral treatment and training for providers to deliver family-based behavioral treatment, so that's an advantage. I'm going to talk about the nuts and bolts. So how does this benefit really going to look in the primary care provider office when kids and families come in, and what happens from there? So this is what I call the ideal state. For those of you all that know about quality improvement work, there's the ideal state, and then there's the actual state of how things really happen. But we think at baseline, the primary care provider would see a patient with obesity and do the recommended assessment and management of obesity in primary care, but also assess them for their interest in a family-based behavioral treatment program. At that point, if the family is interested, they would refer the family for medical nutrition therapy, as well as an initial evaluation for for behavioral therapy. So those would be in individual visits, and then we would want them to arrange a follow-up visit back to the PCP so that they can also monitor their progress. Ideally, the family would then have those individual appointments, and recommendations among the 3 healthcare professionals would be shared so that everybody's on the same page about the treatment plan. They would then begin the group family-based behavioral therapy, and at the end of a certain period, 6 months-ish, then they would have reevaluations by the dietitian and the behavioral therapist, and that progress would be shared back with the primary care provider, who would then reach out to Missouri Medicaid with a status report or a progress report on how that child is doing, and decide on continued treatment if they meet certain criteria, or if they need to step out for a while. So we know there are a lot of steps in filling the treatment gap, and we're addressing the provider and the systems level ones as initial steps, but hopefully by the time we're finished, we're going to have medical providers who are prepared to diagnose and treat and refer, as well as an established certification process for behavioral interventionists to provide FBT. We hope that dietitians will be prepared to do their medical nutrition assessment and provide initial recommendations, especially related to obesity-related comorbidities for kids. And then we'll have a strong referral and care coordination system and consistent messaging. And I think the messaging part is really going to be key in this, and I'll speak a little bit later about what we've done so far with this. So fortunately, we have a pilot grant from the Healthcare Foundation for 2 years to enable us to convene some partners, some healthcare advisors, to help us plan this training and also implement it, and develop best practices for training for those 3 provider groups. We're in the process of training right now, and we expect that we're collecting data as far as how we can improve our training, and hope to modify the training to be even better afterwards, and then create a sustainability plan to reach providers across the state. So the healthcare advisory group has been a really great group of folks to work with, and they've also assisted us with ideas for recruitment, as well as actual venues for recruitment of the different healthcare professionals. They've also given us input on our delivery methods, both virtual and in person, and evaluation methods. And they do represent a variety of perspectives, which we felt was really important for this work to move forward, and are helping guide us about sustainability as well as replication. So this is just a little snapshot of some of the things that I'm including in the medical provider training. I don't want to get these medical providers together without also taking the opportunity to update them on best practices for primary care-based obesity assessment and primary care-based management. So I'm doing a little bit of that. I'm also reviewing the good resources that are already there through the American Academy of Pediatrics Institute for Healthy Childhood Weight and other organizations. We're talking a little bit about weight bias, because it does exist in and among healthcare professionals, and the use of person-first language. What that means is talking about the child with obesity, not the obese child. We want to avoid labeling the child. We also employ a little bit of education about motivational interviewing, just a little bit of teaser about that, and then forward them on to some additional resources for training. We talk about what is the treatment package and what is their role. We see PCPs as gatekeepers, so they're kind of hopefully also the quarterback of the team, in that they identify the patient, they identify appropriate families for more intensive treatment, and then they help coordinate care among the healthcare professionals, as well as solicit ideas from families about how to improve the process. We also talk about what kind of outcomes we might be able to track with not just the training, but also how we tell if the treatment benefit is being uptaken or taken advantage of by the families that are referred. We do offer continuing medical education for this training. So we, again, mentioned a lot of our healthcare advisory group have been great partners in helping us recruit. We have an integrated care system at Children's Mercy that has a network of pediatric practices in the area that accept patients with Medicaid. They have an existing learning collaborative that we've targeted for training. We also have worked with the MU Health Communications Research Center and Natalie Hampton to help research the best methods on communicating with healthcare professionals to interest them in this type of training, and also interviewing key individual providers across the state. We've had the Missouri chapter of the AAP, or American Academy of Pediatrics, which has helped us send out recruitment materials and also given us opportunity to speak at their state conference. We're specifically looking for primary care providers in this pilot phase who not only have a large proportion of patients insured by Medicaid, but also may be co-located with other healthcare professionals such as behavioral health providers and registered dietitians. So recognizing this is not common in a lot of places, but in certain locales such as urban areas that have primary federally qualified health centers and safety net clinics, they're going to be more likely to have access to working with those professionals a little bit more easily than if they're kind of scattered. Also, we're targeting the Missouri Health Net health homes, as well as practices that have an interest or are already set up as patient-centered medical homes. So far, we've trained around 49 medical providers in 3 live trainings, and then we have a videotape training that medical providers can receive CME that's about to go live in the next month or so, and have a few additional live training opportunities in the works. For dietitians, there are a couple of existing certifications through the Academy of Nutrition and Dietetics. One is specific to child and adolescent obesity, and the other one is a little bit more broad, related to obesity. So those are good opportunities that are being recommended. And then in addition, we've conducted a needs assessment of dietitians around the state through the Missouri chapter of the Academy of Nutrition and Dietetics, and got some ideas for what would be the most helpful training elements for them. And I must say, I'm really representing the work of our lead dietitian on this, Karen Stevens, at Children's Mercy. So she's developed the curriculum as well as pulled in additional resources, and has done a couple trainings with around 50 dietitians in the state, and is also videotaping her training. We do have some scope of practice issues, as you might imagine. Dietitians are also on the front line of seeing patients with obesity, and so we are working with them to help identify what are those elements of the treatment package that they are the most qualified to do, which especially has to do with that nutrition assessment and the counseling about comorbidities. And the family-based behavioral treatment provider training status, again, I'm speaking on behalf of Denise and Dr. Meredith Dreyer-Gillette and others at both WashU and CMH who have helped us develop the training package and the venues for training. But it is because the majority of the benefit is directed toward children for behaviorally based treatment. It's a longer training. It's a 2-day training, and we're going to be looking at those providers that are currently licensed by or eligible to be reimbursed by MoHealthNet, which are licensed psychologists, professional counselors, and clinical social workers. And again, Dr. Wolfley and her group are leading this effort, and our initial plans are that we would start training in September and December. These are happening in the Kansas City area. However, they're open to these providers across the state if they would be willing to make the trip to Kansas City. Just lastly, I want to say that insurers do want to see return on investment, which can be difficult to demonstrate in kids because sometimes they haven't yet developed the comorbidities and the associated increased cost, although we see that more and more of them are developing that in childhood. But if we can decrease obesity and its complications in children, our hope is that we can decrease those illnesses in their adulthood and the healthcare dollars that are associated. So we hope that this model that's been developed with Missouri HealthNet can be expanded to children insured commercially. And there are a couple of national initiatives that one has happened and the other one is kind of in the works. The Alliance for a Healthier Generation nationally has spearheaded efforts to engage insurers to cover for medical provider visits and 4 dietitian visits a year for kids with obesity. And then more recently, the My Healthy Weight Initiative was an effort that 11 national insurers signed on to provide at least 12 visits for kids with obesity who are 3 and older, and at least 8 visits for kids who are overweight, who are 3 and older. And the only, in terms of the 4-state region, the only insurer that has signed on to that thus far is Blue Cross Blue Shield of Kansas City. Any of those My Healthy Weight efforts won't start until next year, but we are hoping that they will also be a good partner as we move forward on this. So thank you, and I will turn the podium over to Donna and Deb.